Great. Thank you so much, Cameron. And thank you to all our participants for joining us today for the second in our COVID-19 and dementia webinar series, using technology to provide services to people living with dementia and their caregivers during COVID-19. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start our presentation, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Good morning, everyone. I just want to say a few words to thank you for taking time out of your busy days to join us for this very important webinar. ACL and our grantees have been working furiously to continue to provide services during the pandemic and have really come up with some innovations and great practices, and we're happy that they're able to share them with you. I want to thank Vanessa and Sharon for taking time out of their days to share what they're doing. We're very proud of them, and we hope that you will find the information they provide very useful. And with that, back to you, Sari.
Thank you. Today's presenters are Vanessa Anciani and Sharon Cantrell. Vanessa Anciani is the bilingual social worker at the Latino Geriatric Center Memory Clinic, a community-based memory diagnostic clinic for Latinos located at United Community Center in Milwaukee, Wisconsin. Ms. Anciani is a member of the Mobile Memory Clinic, which has recently been converted to conduct teleassessments due to the COVID-19 pandemic. Ms. Anciani obtained her bachelor's degree from Pontifical Catholic University of Puerto Rico and is currently pursuing her master's degree in social work, physical and health from the University of Wisconsin, Milwaukee. Sharon Cantrell is the Savvy Manager at Amazing Place Dementia Day Center in Houston, Texas. She holds a master's degree in speech pathology with additional experience in neurogenic disorders. Ms. Cantrell also has direct experience with dementia after serving as caregiver for her mother. Ms. Cantrell has worked with the ACL grant program at Amazing Place since January 2018 and has offered approximately 50 Savvy caregiver programs, including 10 of those programs on the virtual platform since April of 2020. Welcome again. At this time, I will turn things over to Vanessa and Sharon.
Hi, again, this is Vanessa. Thank you, Sari, for that introduction. I am the social worker for the Latino Geriatric Center Memory Clinic, and today we're going to talk about how the Memory Clinic adapted to telehealth cognitive assessment for the Latino patients due to the COVID-19. First, let me just go ahead and give you a little bit of history of our clinic. Next slide, please. The Latino Geriatric Center Memory Clinic is a program from the United Community Center. The Memory Clinic was established in 2007 in a collaboration with the UCC, the MCW, the UW-Madison, the Wisconsin Alzheimer's Institute, and the Alzheimer's Association. It is a community-based diagnostic and consultation clinic embedded in the Latino community in the south side of Milwaukee, Wisconsin. In 2018, the United Community Center received an ACL grant to convert the Memory Clinic into a mobile clinic. The project launched in April 19 with a lot of success. The cost of the cognitive screenings are covered under the ACL grant, and the clinical evaluations are billable to the patient's insurance. The Memory Clinic can see one uninsured person a month by our doctor, and our clinic provides cognitive evaluation to all Spanish-speaking Latinos in the community, no matter their immigration status. We are a member of the UW-Wisconsin Alzheimer's Institute Memory Clinic Network, which we collaborate in trainings, clinic operation improvements, data collection, research efforts for mutual benefit. Next slide, please. So right now, I'm just going to present to you who our clinic team is. We have Dr. Piero Antuano. He is our neurologist from the Frederick Medical College of Wisconsin. Al Castro, he's our UCC program director and the clinic manager. Ana Bernan, who is our registered nurse. Myself as the social worker, and Virginia Sedba, who is the Alzheimer's Association from Wisconsin chapter Latino coordinator. Next slide, please. So why did we adapt it to telehealth assessment? Well, first of all, like everybody else, due to COVID-19 pandemic, we were not able to see people in person or no longer do any home visits. We suspended all of our clinic in person and home visits on March 17th. Also, the need for cognitive assessment did not stop. Much needed services for patients and caregivers were still in need. As a Latino nonprofit community organization, we are working with an underserved population in the community. And for us, it was very important, and it was also expected from our community for us to continue to provide services. The population we work with is at a higher risk to develop Alzheimer's disease or related dementias. Cognitive decline or behavioral changes will only get worse if unattended, especially during the pandemic, as patients have to be all day with the caregiver as non-respite services are longer available. The stress from the caregiver will increase and other health issues can arise during the pandemic. Early detection and support services require to be in place as soon as possible for the benefit of the patient and also the caregiver. It was our duty to figure out what to do to minimize the amount of patients in a waiting list, as it can result in future delays of timely assessment and referral for services and resources. Next slide, please. So what was the process for us to adapt into telehealth assessment? Well, we began to do brainstorm and ask different colleagues about different platforms available to begin telehealth services. Our memory clinic manager reviewed various research articles on telehealth usage for background and preparation. We explored platforms such as WebEx, Zoom, and Doxy.me. Next slide, please. So what were some of the technology barriers that we'd encounter? Well, we did an internal scan. So we began by doing an inventory as to what was necessary to be able to provide telehealth services for our patients, what the clinic required, but also what the patient would require. First, we had to choose a web platform in order to do telehealth. After many discussions and research, the team opted for Doxy.me platform as it was also HIPAA compliant, and of course, the HIPAA consideration was taken in place. Doxy.me have the clinic staff the opportunity to have their own rooms where the patient or caregiver can be seen privately. We found that we were lacking computer cameras in order to have the virtual meetings with the patient. Also, we needed to figure out ways to have access to patient referrals and medical records. So for that, we talked to the UCC's IT department, and we were able to link an email address to our fax machine in our office. This way, we were able to check the referrals sent by medical providers from our homes via email. So the nurse was also able to obtain medical records with only verbal consent according to the CMMS regulation changes due to the pandemic. So then when we did the external scan, we wanted to see what the patients and the families were needing. So a lot of our patients, they were lacking smartphones, laptops, or any other form of technology. Some families didn't have any internet, or the internet access was very weak in their neighborhood, especially on the South Side area where most of our patients live. Some, they were not feeling comfortable using technology, and it probably didn't work for all the patients. And also as a clinic, we were also unaware as to what other, if there was somebody else doing telehealth assessments in Spanish in the area. Next slide, please. The slide before. Thank you. So barriers are encountered that we had to consider. So this was the first time for the clinic, just like everybody else in history, to have to deal with telehealth assessments. So we were uncertain as to what to expect in the process. The patients in our Latino community preferred a face-to-face contact with providers. Therefore, it was also going to be very difficult for them to get used to this new technology. Before COVID-19, if the patient was seen in our clinic, the patient will stay in the nurse's office, and the caregiver will go to my office while doing the assessment. It was easier to separate them in order to obtain the information needed. The same was when we used to do the assessments in the home. The nurse will stay with the patient in the dining room area, and the caregiver will opt to go to the kitchen or living room for more privacy during the assessment. Another barrier that we encountered was the inability to complete the home safety assessment. With this assessment, during the home visit, the memory clinic team were able to identify potential risks such as falls, and the nurse was able to provide recommendations and other options to avoid those risks during the home visit. Also, the inability for the doctor to complete physical exam was also present as a major barrier. Next slide, please. So we need to do an inventory about the equipment and supplies that we needed. The nurse and myself, we began to work on our personal laptops, which we still do if we are home. However, the cameras with microphones were purchased in order to conduct telehealth assessments and other virtual meetings while in the office. 2 Chromebooks and 2 internet hotspots were purchased prior to the pandemic, thankfully, and the team decided it was best to use it by the patients lacking technology. As we care for older population, we encountered that some of them were hard of hearing, so we decided that headphones with disposable covers were needed in order to ensure better service for the patient while doing cognitive assessment. With the platform that we purchased, which was the Doxy.me, it was also easier for the caregiver to access the page since no application has to be downloaded. Ziploc bags were purchased in order to store the Chromebook and hotspot when delivered to the patient. Sanitizing supplies such as cavi wipes were also purchased in order to sanitize the equipment before and after each visit. Next slide, please. So some of the adaptations that family members and the patients have to do for the technology. During the initial call, I explained to the caregiver what to expect from the initial assessment visit. I also inquire if they have any technology available for the appointment day. Otherwise, I let them know the equipment can be delivered to them. If they do have available technology, sometimes the caregiver has a hard time accessing it on their own. And that is when the nurse or myself, we turn into IT experts and assist the caregiver via phone as to how to access the link that was sent to them. If after many trials and the caregiver is not able to access them, then what we do is we reschedule the appointment for a later time in the day and deliver the Chromebook and internet hotspot to the caregiver in order for the patient not to miss the appointment. Next slide, please. So what are some of the safety precautions that we are taking? So of course, in order to protect our patients and staff during the pandemic, the safest way to continue to provide services were with the use of the telehealth. Also, either the nurse or myself will deliver the equipment, making sure that we have masks and gloves that our gloves are on. The Chromebook is set up before it is delivered. This way the caregiver does not have trouble in accessing the link. The nurse or myself, we call the caregiver outside the house and we turn in the equipment with verbal instructions to return the equipment to its specific bag when it is picked up. Or the nurse or myself, we repeat the same process when picking up the devices, wearing a mask and gloves, and sanitizing the equipment for the next assessment. Next slide, please. So what is the actual process of the virtual screening? So we recommend not to see more than one patient a day for initial assessment, since the test can take about 1.5 hours to 2.5 hours on screen time. And also it takes about 30 extra minutes if the Chromebook and the hotspot needs to be delivered to the patient. We also held team meetings 10 to 15 minutes before the scheduled time just to discuss the case and to make sure all the information is accurate. After the nurse sends the link via text or email message to the caregiver in order to access the Doxy.me platform, the patients without technology, either the nurse or the social worker ensures the equipment has been delivered at least 15 minutes before the appointment. When the appointment starts, I will do the introduction of the team and ask the patient if he or she are aware of today's visit, and if not, I will explain to them what is it that we're doing on that day. Then the nurse reads the permission to consent for treatment and authorization for release of information on the screen to the patient and the caregiver while showing both documents on the computer screen. The nurse later asks for the medication list and writes them down. After all of this is done, I will ask for insurance if there is any insurance available. After we gather all the information that's needed, then I will excuse myself from the screen, and then I will let the nurse and the patient continue with the cognitive assessment. So some of the cognitive tests used by the RN are the MOCA A, the MOCA B, the ANT, and the MiniCog. She also uses the assessments in the Geriatric Depression Scale, better known as GDS, and the Dementia Quality of Life. While the nurses completed the cognitive evaluation with the patient, what I do is I'm on the phone with the caregiver, completed the caregiver interview. The reason that I do only telephone interviews to the caregiver and not in telehealth format is because we don't want to put more pressure on the caregiver to have to sit still in front of the camera to talk to me. Almost all the caregivers are doing other house chores while they are talking to me or taking care of their children that are doing homeschooling due to the pandemic. Some of the assessments used during the caregiver interview are CATS, the Lawton Safety Assessment, Neuropsychiatric Questionnaire, Memory and Behavior Problem Checklist, GDS Proxy, and the Xeris. After the nurse completes the assessment with the patient and I complete the assessment or the caregiver interview, the patient and the caregiver are placed on hold while the team discusses the patient's test results and the information provided by the caregiver. While the patient and the caregiver are in the waiting room, they have access to educational videos in Spanish they can explore while they're waiting. After we finish with our team meeting, the patient and the caregiver are returned to the main room and then the results are discussed and the decisions of following up with the doctor or not are also discussed. If the patient has to follow up with our neurologist, we schedule the patient right away for the next clinic, which is usually after 5 weeks from the initial visit. And if the patient does not have to be scheduled for the clinic, a letter is sent to the primary care physician explaining why the patient does not have to follow up with the neurologist and to continue to follow up with the patient as needed. Next slide, please. So what does it look like when Dr. Antoine, our neurologist, has to evaluate our patients? So the doctor's evaluation takes approximately 45 minutes. You also have to add the 30 minutes needed to be added in case you have to go and drop off the equipment to the patient's home. We have 2 clinic days per month, of which the team is able to schedule 3 patients for each clinic a day. The memory clinic team staff at least 15 minutes before each appointment just to ensure that all the information is accurate and you know, also in case some questions arise from the doctor or any other clinic team. After the meeting, the nurse sends the link to the caregiver, and once they are in the waiting room, the nurse lets them in the room with the doctor. During the doctor's appointment, the caregiver, the patient, the doctor, the nurse, and myself were all available on screen. The nurse introduces the doctor to the caregiver and the patient. The nurse inquires about any changes in medications and pretty much asks overall health questions. And afterwards, the doctor completes evaluation by asking patient and caregiver questions about how is the memory, have they seen any changes, etc. So during the doctor's evaluation, the doctor evaluates the patient neurologically and cognitively by using different tests that are screen friendly. Some of the tests can be using the computer screen or cell phone. The doctor asks the caregiver to show how the patient walks to assess balance and ambulation. And also the doctor tests the abstraction to see if there is any frontal lobe dysfunction, utilizing different proverbs that are culturally appropriate in Spanish. After the doctor is done with assessment and diagnosis, recommendations are provided, and we refer them to the Aging and Disability Research Center, the Senior Center, the Adult Age Center, or the Alzheimer's Association. We also emphasize on the caregiver to assist the patient to complete the power of attorney for healthcare. And we also recommend to our caregivers to call the 211 community information number, which can assist in case they require other resources such as housing, food, or mental health services. Next slide, please. There you go, thank you. So how do we connect with the Alzheimer's Association? Well, all the referrals are made via email to our bilingual outreach coordinator at the Alzheimer's Association. The reason the Alzheimer's Association coordinator is not present during clinic days, as she will usually be when we're seeing patients in clinic, is because we don't want to confuse the patient and the caregiver with having so many faces on the screen. This can create a lot of confusion, and the patient also might feel a little bit overwhelmed. The Alzheimer's coordinator calls the caregiver within 1 to 2 days and provides them with more information about the diagnosis that was given and what to expect in the future. Care consultations are also scheduled to be done via phone, and they are either in Spanish or English. The Alzheimer's Association coordinator also holds monthly virtual support groups in Spanish for those that are interested to participate. And for now, we have the Cuidando con Respeto, which will be the Savvy Caregiver, on hold due to the pandemic, and we're trying to explore different alternatives as to how to provide these classes to our caregivers in the community. Next slide, please. So what are the benefits that we have found with telehealth? Well, during the current pandemic, the patient and the staff are less exposed to the virus. The initial appointment for assessment can be done later in the day, as some of the caregivers are essential workers and cannot take days off. A lot of them work in companies and factories. It increases access to other areas that don't have Latino providers. We were able to see patients from different areas, such as Madison and Kenosha, which are located far from our Milwaukee County area. The patients can make it to the appointments no matter the weather condition, as it gets very cold and very snowy here in Milwaukee. And it can also involve caregivers that live in a distance, and more than one family member can be available at a time. Next slide, please. So what are some of the limitations? As anything with telehealth, we have encountered some limitations by accessing our patients using this platform. Some of the limitations are that some parts of the assessment, such as a home safety assessment, cannot be done as the team is no longer able to enter the home. Also, we're lacking the personalismo, which it refers to the personal connection and interaction Latinos highly value. The Latino community prefers to have a face-to-face visit with all medical providers. Latinos feel more comfortable in sitting in a doctor's office and talk about their problems, hoping for a quick answer. Telehealth is not good for people that are hard of hearing. However, we have fixed the problem by purchasing new headphones with disposable ear covers. This has helped patients who otherwise would have a hard time following along with what the nurse is telling them to do on screen. It is also not convenient for patients that have poor vision, as they are not able to see the exam on the computer screen. However, we have resolved this issue by using the Mocha Blind version, also using the ANT and the word recall. Telehealth would not work for patients with more advanced cognitive decline, and this is because they will get easily confused with what is presented to them on the computer screen, and also they can become agitated. It can be more time consuming, as we have to travel back and forth to be able to drop off the technology for our patients. Next slide, please. So what are some of the key recommendations for everyone that is trying to do telehealth in a clinic like ours? So make sure to do an inventory of what equipment and infrastructure is needed before converting to telehealth services. Take into consideration what are the needs, the cultural norms, which is important, and socioeconomics of the community you are serving. Choose a good virtual platform that is going to be easy for the staff to use and easy access to participants and caregivers. Before you start telehealth with your patients, make sure you practice within the clinic staff many times, as it can be some time to get used to it, to the platform, and learn how to work. I know it took us about a month before we were able to launch our platform. Always have a plan B in case the technology does not work. Probably think about rescheduling the appointment at a later time or day. Some patients with more advanced or decline memory issues may not be able to use the technology. It is too complex for them. So it's better to stop or not to schedule for telehealth and pretty much having them on a waiting list. Remain flexible, change and adapt as needed. And last but not least, I think the most important of all, have lots of patience. Technology not always works on our side, and we must come up with many ideas to ensure the patient is able to complete the appointment. And that has happened to us quite often. Next slide, please. So what do we see where telehealth is going? So it can be beneficial to schedule later in the appointment for those caregivers that are essential workers and can't take time off for appointments during typical clinic hours. It can also reach patients not living in the immediate service area of the clinic or have difficulty getting to or from the clinic. It can help involve caregivers, family members that live far from the patient. For example, we had a patient living here in Milwaukee, and we were able to talk to the caregiver who lived in Minnesota. During the pandemic, it helps to maintain safety and social distancing for patients and clinical staff. It can potentially increase the usage and research opportunities to do on the feasibility of the telehealth for dementia patients or with other morbidities. And it can also potentially use for family caregiver support and other kinds of educations. Next slide, please. So there you can see my contact information. If you have any questions, there is my phone number and my email address. Thank you so much for your time. Gracias.
Excellent job, Vanessa. Thank you for your wonderful work. Hello, everyone. I'm Sharon Cantrell, the Savvy Caregiver Manager for Amazing Place. I'm also a master trainer for Savvy Caregiver Program, and I was trained by one of the authors of Savvy. I'm still on the first slide. We are all here today because we care about people with dementia and their caregivers and have been working to find ways to meet their needs during COVID-19. I will be presenting how Amazing Place implemented Savvy, an evidence-based in-person intervention, to an online platform to benefit caregivers. Next slide, please. Now I'll tell you a little bit about Amazing Place. Our mission is to empower lives disrupted by dementia, from day program participants and families to caregivers to health professionals and also our congregations. We are a faith-based organization in Houston, Texas, with this vision, ending the stigma of dementia. We are looking forward to our special 25th anniversary year in 2021. The day program serves mild to moderate dementias and is currently offering an innovative virtual day program. The Connections program offers support and comprehensive education at Amazing Place and in our community. The Savvy program is under the Connections program. Next slide, please. Next slide. Thank you. Amazing Place began offering the Savvy Caregiver program under grant in May of 2018. Cumulatively, until March of this year, we partnered with 16 local churches. We offered 38 Savvy Caregiver programs. We enrolled 284 caregivers who demonstrated high levels of satisfaction and increased self-efficacy. Next slide, please. COVID-19 has dramatically impacted us all, and it continues to do so. Amazing Place and our partnering churches closed temporarily. The final in-person Savvy Caregiver program was March 19th. Transitioning the Savvy program quickly with the emphasis on fidelity, Amazing Place offered the first virtual Savvy on April 20th. Next slide, please. Amazing Place adopted the Zoom virtual platform because it was user-friendly, reliable, and had features which facilitated our various programs. Further, it was widely adopted by our partner churches and our community. Privacy, HIPAA compliance is protected by the waiting room and ID features. Next slide. Technology challenges for Savvy facilitators. Immediate challenges focused on becoming familiar with the Zoom platform and just identifying the features which would best facilitate a virtual delivery of Savvy. Further, we needed to determine technology capabilities of interested class participants. So we used a technology survey to poll participants and record which ones were going to need tech support. Virtual Savvy needed to be interactive, a component required for successful Savvy. Guidelines were established to manage features helpful to interacting. It includes camera level, screen views, and audio features. If you've ever presented to a group and you see the very top of their head or the bottom of your chin, you understand the camera level. It sounds, a lot of these things sound very, just basic, but our participants didn't know really how to manage those at first. Next slide, please. So caregiver challenges. Would caregivers be interested in a virtual program? Could caregivers do a 2-hour session? Could we find a time that would work for most caregivers? Would caregivers be comfortable interacting from home? Would they be able to share their concerns with care receiver in the house? Would they bond as a group on a virtual platform? We found that caregivers were interested, even eager to participate in a virtual Savvy. Caregivers were able to make the 2-hour sessions work, and it was determined 11:30 to 1:30 was a popular time. They were eager to share and strategize. They were bonding in the virtual setting. Using headphones and the chat feature, they were able to still share when their care recipient was nearby. Next slide, please. virtual savvy program challenges. It was important for delivery of the Savvy curriculum on the virtual platform to promote the same engagement, learning, and strategizing as in-person Savvy. With screen sharing and using side-by-side mode, the presentation of slides is inclusive to the participants. You will see an example of this in the next slide. We also found gallery view facilitates discussion and sharing. The participant manuals, they needed to be distributed electronically, but to facilitate ease of use, a lot of our population found it hard to use the caregiver manual on the email, so we made arrangements to actually distribute the hard copies, and we mail to those that are out of state. Protocol was established for the integrity of virtual data collection using SurveyMonkey. Protocol also includes standardized email to introduce data collection and an independent data entry person. We collect demographic data, grant-related data, and outcome data at Amazing Place. Next slide, please. So during the period of April through August, we partnered with 7 local churches, offered 8 virtual Savvy programs, enrolled 54 caregivers who demonstrated high levels of satisfaction and increased self-efficacy. Here you can see an example of the side-by-side view during virtual delivery. Next slide. In this slide, we see the comparison of scores between in-person and virtual Savvy. Data comparison shows highly significant improvement in self-efficacy after 6-week in-person and virtual Savvy. Virtual Savvy demonstrates an even higher significance shown by the t-test scores here. Next slide. This slide shows more exciting data. This is caregiver satisfaction and retention rates. Satisfaction rates in-person Savvy, 98.5%, virtual, 100%. Retention rates in-person, 85%, virtual Savvy, 96%. Next slide. I would like to share this feedback from a virtual Savvy participant. I am so glad to see you are able to offer Savvy Caregiver on Zoom. What I learned in your class has been so helpful throughout this crazy time. I knew more what to expect and how to deal with it. My husband and I are both doing much better than we would have without the knowledge. Next slide, please. So this slide's kind of an emotional slide for me. I am a huge, huge fan of the 6-week in-person Savvy. And when we had to transition quickly to deliver Savvy virtually, I was afraid it might be just a stopgap and it would not meet the caregiver's needs sufficiently. Yes, and that people would not bond in the same way, or they wouldn't feel that it was a safe place to talk about their issues on a virtual platform. I have been very thankful to see significant benefits of virtual Savvy. This has been a real silver lining during COVID-19. Collaborative caregiving is a very important goal in the Savvy program, and it has been greatly facilitated by remote family members attending the same class and using Savvy models to problem solve together. Many participants in the past 8 virtual Savvy programs reported they would never be able to attend in-person Savvy for different reasons. They work full-time, have no respite care. There were no Savvy programs in their area, to name a few. Many spoke of the added difficulties, the extra layer of challenges of COVID-19 and the isolation, and how helpful it was to talk with others who understand what they are going through and strategize together about issues during this time. Clearly, we have seen tremendous benefits of virtual savvy. We have seen increased interactive strategizing, increased collaborative caregiving, greater geographic access with participants from many different states. To date, virtual savvy has served over 50 zip codes. We have seen removal of barriers to access savvy and decreases in social isolation. I have no hardcore evidence tracking decrease in social isolation, but I have observed caregivers bonding, exchanging phone numbers, wanting to sign up for other virtual savvy programs altogether, and helping each other get their hard copy caregiver manual, which is very important to them. I have seen them reaching out to comfort each other during this time of COVID. I am hoping this information will provide encouragement for others to consider offering hybrid savvy programs with both in-person as COVID permits and virtual. Next slide, please. This vignette demonstrates collaborative caregiving and problem solving facilitated by virtual savvy. Anne is a 64-year-old retired minister diagnosed with mild cognitive impairment. She has been married 6 years, her second marriage. She lives with her husband locally. Her sister lives 2 hours away, and her daughter lives in California. The husband, sister, and daughter enrolled together in virtual savvy. They were all concerned and wanted to help Anne. The daughter and sister felt reluctant to interfere, and the husband was not comfortable calling the daughter or sister for help. Initially, they were awkward and cautious in their interactions in class. These were their concerns. They were worried about her finances. She still had all of her finances separate. She did not want to tell any of her friends about her diagnosis. She was not socializing. She was having immediate and recent recall difficulties and finding it difficult to complete her daily task, forgetting to eat. She was becoming very anxious about mistakes that she realized she was making. Next slide, please. So attending Savvy together, watching the DVD on dementia stages, discussing and applying Savvy models, they came up with a collaborative plan for Anne. These are some of the strategies they came up with. The husband was going to take control over her finances. He was going to simplify and organize the house and their environment and set up schedules for meals and daily routines so that it would be very consistent for Anne. He practiced redirection to help her complete tasks. They were all aware that they needed to increase the amount of encouragement and reassurance they used with Anne. They were planning cognitively stimulating activities appropriate to her stage of dementia. The sister was going to call a minister friend and let them know her diagnosis, let them in on this and ask them to FaceTime her, call her regularly, someone to bring Anne out about her past accomplishments and her faith. A journaling project was going to be started by the daughter. So critical components for success. We decided that organizational commitment was extremely important. Commitment and support is very important for a professional virtual platform. Preferably, Savvy facilitators should be experienced with the 6-week in-person Savvy program. Reliable technology for delivery is critical, of course, including quality video, sound, computer, and or laptop. Available assistance for caregiver participants with technology issues or questions is critical. Caregiver participants should be present in video and audio for interactive dynamics in the class. Target marketing is very important to make sure the dementia caregiving population is aware of the virtual option. Next slide, please. So these materials are available. They are documents developed to facilitate quality and facility of virtual savvy. And they are, you see the virtual savvy caregiver guidelines. That's a blueprint, an outline for virtual classes, including populating them, screening, enrollment, registration for class link, and virtual etiquette. There's our technology survey we use, sample standard emails, and example also of our informational marketing flyer, virtual train the trainer and peer review protocols, other adapted ACL grant protocols, such as the virtual consent letter, secure pre and post data collection, and anonymous satisfaction surveys. And there is my email contact. So thank you very much for your time. We are thankful for our ACL grant. It wouldn't have all been possible without support from them. Thank you very much.
Thank you so much, Sharon and Vanessa, for your wonderful presentations. We'll move to questions in just a moment here. I want you all to be able to know that you can submit your questions through the Q&A pod on your Zoom screen. And we will be getting to those in just a minute. I'll just let some of those questions filter in. All right. So if you could talk a little bit about, well, a lot of people are asking about the PowerPoint slides. We will be able to get those to you once I have a participant list. So sit tight for those. I will send them as soon as I can, as soon as I have everyone's email addresses. So we had a question here about marketing. How are you able to reach caregivers with virtual programming? How do you market to them and get them to know about your programs? Can you each respond to that about how you were able to get folks to know about what you were doing? And if they weren't current clients, how you were able to find new clients?
Hi, so this is Vanessa. In our clinic, in our case, what we're doing is we're using the Facebook platforms. So pretty much we're sending a message through Facebook, flyers, letting the community know that we are still open. A lot of people thought that we were closed because of the pandemic, but they didn't know that we were doing the telehealth assessments. So pretty much that's what we're doing, just using the platforms, Facebook, Instagram. The United Community Center continues to provide flyers with our information, and also with the new information that we're doing telehealth assessment. Also, we let all of our doctors around the area where we receive most of the referrals from. We have also let them know that we are doing telehealth assessments, so we continue to be open. And during the initial phone call that I made to the caregiver just to see how we can help, I also let them know that we are doing telehealth assessment, that we no longer are able to see people in our clinic or in person at home. So that's the way we have been able to market what we're doing now with our clinic with telehealth.
Great, thank you. Sharon, would you like to respond?
Yes, we market through our partnering churches. When we were in community, they were hosting the Savvy Caregiver programs for us. It was part of the grant work. So I was delivering the Savvy Caregiver programs in our churches and at Amazing Place also. So that was a good way to get the word out that there was a virtual savvy, circling back to our partnering churches, sending them the informational flyer, and they would market that to their congregations. That was a big help. To our Amazing Place database, we could send out the information. Our website was another really good source. When people clicked on the cover page, it was very clear cut that that there was virtual offerings at Amazing Place now. Also Facebook, Instagram, we have had some NPR ads that I've gotten good response from. And also I've just seen word of mouth.
Great, thank you so much for those responses. You both talked about conducting screenings, assessments, other types of measurement tools while you're on the phone or having a video meeting. Maybe you're sending those assessments. Can you talk about maybe how you had to modify those procedures for remote options of your programs? Sharon, do you want to start?
We put our measurements, which is our surveys are the demographic survey, modified self-efficacy, the Zaret burden. Those were pre-data collection, and those went into SurveyMonkey and by email. So they were, as people enrolled through me, and they were screened if they were appropriate for the Savvy program. Were they a professional? We made sure that they were an appropriate family caregiver. Then we screened them also for their technology, and if they were going to have issues, did they need any extra assistance? And then once we had, they were screened, they were enrolled in a program, and they were sent a few days before the beginning of the first session, the pre-data collection in a SurveyMonkey form. Attached to that was also the assumed compliance with reading the virtual consent letter. Does that answer your question?
That's great, thank you. Vanessa, do you have anything to add for how you did things with your program?
Sure. So pretty much just like Sharon said, we have to, I call the caregiver and I will ask if they have any technology available in the home. And if not, one of the changes that we made is us bringing the technology to the home. So there is no excuses for the patient not to be able to be seen by our clinic. Most of the assessment that we still do are the same assessment that we used to do in the home and in clinic. The only thing that has changed is that the nurse is no longer able to do the safety home assessment just because we can no longer go in the house anymore. Of course, the assessment from the doctor has changed a little bit more. Now he depends more on the caregiver to answer a little bit more questions, or for the caregiver to use the phone or the camera for him to see the patient walking, just to see the balance and things like that. And pretty much just using more questions than the physical assessment that he used to do at the clinic. But otherwise, those has been our primary change was bringing the technology into these patients and caregivers' home that are lacking of internet access and computers and other devices.
Great, thank you so much. Sharon, the next question is mainly for you. Did you have any caregivers who may have been reluctant to participate in your program because they were at home with the person living with dementia and concerned they might overhear things that are difficult for them to listen to about their dementia diagnosis and other aspects of living with dementia?
Yes, and we were able to give them information that if they had a headset, earphones, and they could use the chat. So I had a colleague was assisting me and helping me with some of the those type of technology things. And there were phone calls made and like kind of walking them through it ahead of time, how to type your question or your interactions in the chat while your loved one was nearby, and using the headset so they couldn't hear what was going on in the class. And that really never had anybody who had to just drop out. It seemed to work very well, and their care recipient usually didn't stay there for long. They might be kind of wandering in and out. And the time that I said turned out to be popular, 11:30 to 1:30, was because they could set their loved one up with lunch, and they would be busy for a while eating lunch, and then they might wander in some afterwards. But I didn't ever have anybody who couldn't participate because of being there with their loved one.
Great, thank you.
Mm-hmm.
Similar question, can you think of a situation where someone might not be a good candidate for the virtual approach for either of your programs, where remote really could be, the challenges may outweigh the benefits? Are there any situations like that you've encountered or can anticipate?
Well, I can take that as far as I do see there are some care recipients that need total care, and that is kind of part of the screening as well. If their care recipient is still able to do things on their own and a little independently, even be in front of the TV in another room, eat their lunch independently, then that's just another part of the screening. You ask those questions. If they are trying to take care of someone at home and they don't have any respite care, anybody, a family member to come sit for a little bit, then they are, counseled that it would be very difficult for them to be able to participate. And then we put them on the waiting list and keep in touch with them, circle back, and in case their situation changes, but keep them on the waiting list for when we can be in community again.
Great, thank you. Vanessa, do you have anything to add about that? Were there any people in the community that really just, it hasn't been easy for them to participate remotely?
Sure. So we have about 6 patients right now on the waiting list. And this is because when we started to do the virtually assessment, a lot of them had a little bit of mistrust of what's going on with the pandemic. They pretty much, they don't trust, the health department. They don't trust the government. They have a lot of trust issues. So a lot of them just prefer for us to assess them when the clinic reopens again. So that has been, one of the setbacks for us. But for the rest of the time, or most of the time, everybody, they are in agreement for us to do the telehealth assessment, just because also their primary care doctors are doing telehealth assessment. So now they have become a little more, more, they trust a little bit more what's, with the telehealth assessment in their community. But certainly we have 6 people still waiting for us to open our clinic in person. So there's a lot of mistrust, but we continue to work on it.
Great, thank you for pointing that out. Can you both talk a little bit about how you decided the technology you were using, whether it was for Virtual Savvy, the Zoom platform, or for you, Vanessa, the Chromebooks, how you decided what technology to use, why it would be best for your program? I know you touched on this a little bit, but there's a few questions about how you really decided what would be best.
Sure. So we decided for Doxy.me platform, and this is because it's HIPAA compliant. We are seeing patients, so we want to make sure that all of their all of their records and all of their information are shared in a safe platform. So of course, that to me is a platform that you have to pay for. So it makes it probably a little bit more safer. And it's also a platform that a lot of our physicians around our clinic are also using. And the Chromebooks came about because we started to notice that a lot of people will say, well, you know, we do have a cell phone, but we have the flip-flop phones. And you know, they didn't have any phones with camera, etc. We have already purchased 2 Chromebooks in the past before anything of the COVID-19 happened. So we were lucky to have those handy, and also the 2 hotspot Wi-Fi's. So that's how we came about of, you know what, if they don't have any technology, let's bring the technology home, and we're still going to be able to, see them and do the assessments. So that's how the Chromebooks came about.
Great, thank you. Sharon, can you talk a little bit about how you decided on what technology to use, a little bit more about the Zoom option?
Our organization decided on Zoom, ours had to be very user friendly with our population. They were trying to find something that would be effective for the virtual day program that they were offering, and for Savvy, and for our other virtual programs as well. Then to be user friendly with this population, of course, was very important, and it is reliable. It's HIPAA compliant if you use the waiting room and the ID features, which is you buy a certain business platform that has the features, and like I said, our partner churches, our whole community widely adapted Zoom. So we needed to have a platform that we could connect with our whole community.
Great, thank you so much. Well, I want to thank you both again for your wonderful presentations today and for sharing so much knowledge with our participants. This has been wonderful. As we were moving into the questions section, we did put up a last slide. You heard from both of our speakers that they benefited from funding through different ACL dementia grant programs. If you're interested in learning more about those, you can set up a notification on grants.gov to find out more about the opportunities in the future. So at this time, I just want to thank you all for attending. Again, we will send slides out when I have the attendee list. And until that time, we want to thank you for joining us. Please join us also for our last in our webinar series on COVID-19 and dementia, which will be November 19th, maintaining services and supports for people living with dementia and their caregivers during COVID-19. Registration information for that webinar can be found on the American Society on Aging's website. Their website is asaging.org. And that's the American Society on Aging, and we hope you'll join us for that session. So thank you, everyone, and have a lovely afternoon.